So the previous talks have given you problems. I'm going to give you the solution. And even better, we're going to get it right first time. This is a name which is entirely free of irony and is, as you'll discover. So anyway, getting it right first time. I don't know how much you know about it, but the whole idea is that we actually use data to try and improve clinical services. Obviously, we all realize that what you measure, what can be counted, what counts can be counted, but not all that. This is quite tricky, isn't it? Not everything that counts can be counted, and not everything that can be counted counts. And obviously we have to recognize that we don't get really fixated on data that we've got, and we try and make sure we use data which tells us stuff. Broadly speaking, the question we're going to be asking when we come round is, how well do we look after patients with neurological diseases in the relevant area? Now this is old data, but you can see there's substantial, this is by CCGs, there's huge variation in data and access to neurology services from really very dramatic levels. The tests we do, there's been dramatic, huge fold, 15, 20-fold variation access to different tests. So variation is clearly there. And what the GIRFT process has done, and it's been developed by Tim Briggs and started off with orthopedics, and I'll show you some of his data, is to take nationally collected data, get some data about local services, take people their own data. Obviously, people who look at hip and knee replacements, you tell them their infection rate, you tell them how long patients are in hospital in their unit, they get a data pack, you then visit the trust, you tell everyone this, you produce a specific report, it feeds into the national report, you tell them what they should do to try and improve that. People knowing their own data is a really important driver. Most people don't actually know what or didn't, in Tim's experience, didn't know what their infection rate was, which seems surprising, but they didn't know. And cardiac surgery, they probably didn't know their mortality rate. But if you tell them, then they change. And the whole point is you don't get it right first time, you repeat. It's a cyclical, it's an iterative process. And if you look at the data from orthopedic surgery, the post-operative infection rate ranged from 0.2 to 4.5. That's a staggering variation in infection rate. The surgery costs varied from 530 to 2,800. You can see why the Department of Health is really quite keen on the whole programme, because potentially it's identifying huge differences in cost. And there was the same rods were being bought in one hospital for £72 and by another for over 1,000. So it's huge variation. This is a cemented hip. And if you look, these are different trusts. The expensive ones are over here, the cheap ones are on the left, and you can see that depending where you were, it's just absolutely random. And one of the key features of this kind of work stuff is that you see this huge variation. And obviously, neurology is more complicated. I hate to suggest that cardiac surgery is easy, but neurology is much more complicated. And we've got problems because we've got lots of complicated diseases. We've got lots of different diseases. We've heard a discussion about outcomes, even just touching, but that's just by one disease. But how do we work out the outcomes in epilepsy, MS, Parkinson's, lots of difficult measures. A lot of what we do, all our outpatients, is not coded. You've got the 3 codes, new, follow-up, DNA. Not very informative. We've also got lots of organisation. Because of the way in which neurology has evolved in the UK, we have a situation where different hospitals do different things. So you have DGHs, some DGHs have neurologists, some DGHs, the neurologists visit from somewhere else. You have neuroscience centres, some of which, so there are neuroscience centres which have neurosurgery but no neurology. There are some which have neurology but no, it's extraordinary. Everything that you could think of, every combination is available. And each region has come up with a different set of solutions. And you can understand why that might be, but it makes comparisons really quite challenging. And a lot of what we do, for example, all the stuff where we go and see ward referrals across most of the country, but not all of the country, is not measured. So a huge and important part of the work neurologists do is not accessed. So obviously this makes it quite tricky. So how do we start to try and make sense of this? Well, many of you here, I don't know how many, have filled in our questionnaire that we did with the GIRFT and ABN, which was based on hospitals rather than trusts, because trusts just keep changing. So they'll have one hospital in it, they'll keep merging. Birmingham's a very good example. I don't know, Adrian's not here, but they've just changed, they've reclassified them all, so the trusts are all going all over the place. And this is the various centres that we got. So we started off with neuroscience centres, which are purple, which is where you have neurology and neurosurgery. Neurology inpatient centres, and then you can see they're scattered around. DGH is where the neurologist is based there, but they don't have any inpatients. And then the green ones are places where neurologists just visit. So you can see it's a really dramatic sort of hodgepodge kind of stuff. And I'll show you some data, because we've got some very preliminary data, and I'm keen to show you some information. So these are our neuroscience centres, and you can see they mostly have quite a lot of consultants. They have registrars. They have about 20 beds. They do about 40 clinics a week. They see quite a lot of referrals. And most of them offer thrombectomy and thrombolysis. So you can see these are up and down the country. We've then got neurology centres, which have evolved, and a lot of them are relatively more recent. And you can see that we've got about 5 or so neurologists in each place. There are a smattering of registrars, normally an average of 2. They have about 8 or 9 beds, and they do about half the number of clinics a week. So these are quite busy centres. And they do thrombolysis, but they don't do thrombectomy, pretty much. And then we've got the DGHs, which are where you have neurologists, and mostly there are about 3 of them. One of them comes from somewhere else. They tend not to have registrars. Astonishingly, even though we define people as not having beds, they have an average of 1.3 beds. And they are less active. You can remember we had from 40 to 20, now about 10, and they typically also offer thrombolysis. So these are reasonable-sized DGHs. And then we've got places where neurologists visit. And you can see, interestingly, there's a very clear model in Manchester, Liverpool and Sheffield, which has very much retained a very strong hub and spoke model. And you can see they're much slightly smaller units, tends not to have registrars, smaller numbers of clinics, and only about half of them provide thrombolysis. So we've got some spectrum of different stuff. But each model, and you can see from that, each model has been different in different geography. And so how do we try and get across these different regions with different problems and try and get reasonable comparisons? So you're being compared with people where it's justifiable and it's appropriate to be compared with them. On top of that, we've got different disorders, and we'll come back to some specific issues around MS, but clearly services which have to be provided very close to home, how you look after patients with MND, for example, you'd want that quite close to home. If you've got something like MS, you will be thinking much more on a sort of centre or a network basis. Let's think about some of these. We've got acute neurology. Well, anyone who's got an acute take needs to have a problem. So this is a trust-based problem. So every trust has got the same set of issues. Epilepsy, we just mentioned, you want, it's hard to travel if you've got epilepsy, so you want it close as you can manage, but you have to have access to epilepsy surgery, so there's a bit of a conflict. And MS, clearly you have issues about wanting to be close to the patients and yet having an appropriate network of a subspecialty, which is actually one of the few subspecialties in neurology which actually is a line drawn around it, because you either prescribe or you don't prescribe. You can't prescribe a little bit of the disease-modifying therapies. So we can't look in trust in isolation. And so the solution we've come up to is to look at each neuroscience region. Now, at some stage in the distant past, the hospitals that became neuroscience centres were the centre of some sort of NHS organisation. But a lot of the time those organisations have changed, barriers have all drawn, it's all become a mishmash. So what we've done is we've defined neuroscience centres as neuroscience region as the DGHs and area that feeds a neuroscience centre. We also need to look at the trusts individually. This is an example of Addenbrooke's, and you can see the whole idea of a hub and a spoke. And so we've got a neuroscience region. And because we've got a neuroscience region, we can actually draw a line around it and get a reasonable, accurate population basis that this neurology service for all of these things actually is provided for. So we have a denominator. We know what population we're comparing it to. So we can make some sort of... it says TV will turn off automatically unless I press. I've got 54 seconds to do something, Mr. AV man. If you could do whatever the thing is in 54, that'd be absolutely splendid. 45 now. Anyway, on we go. So you can see, once we've got a population, we can do more interesting and not fantastically valid epidemiology, but at least reasonable epidemiology. And here's Bristol, which you can see, again, a different sort of organisation. So our plan is to have a neuroscience regional meeting, so to present data not just to the trust but to the region. And the idea is that we would hold it, and we're booking them all up for next year, a presentation where we talk about data on your region and compare it to other regions. So we've got a population, and so we can have some sort of population-based outcome. Obviously the problem we have is regionals. We've got 4 seconds, by the way. It's gone. It's gone. So we're all on the same page here. So the regions overlap. So there are some hospitals which half their work goes one way and half their work goes the other. There are some trusts, and a lot of the data in HES and various things is collected on a trust basis, where half the hospital sites in the trust and half go to one centre. And so you can see it's all a bit messy. And we've had to try and make some decisions to try and get over that to get coherent numbers. Some hospitals will send their epilepsy this way and their MS that way. So we've got all kinds of messes going along this. And well, I don't know anyone here from Wexham or Frimley, but Wexham used to go to Charing Cross, now it goes to St George's. So the data a year ago, it was one neuroscience region, the data this year is another one. So you can see everything's a bit of a mess. So we're having to get the best answer that we can. And obviously a lot of places will do a super regional activity which might distort it. However, we'll then have a second iteration of meetings where we go to every trust and give people information about themselves, so that they will know what they get up to. And obviously that's going to be particularly important for acute neurology, which is going to be at every trust and every site, and perhaps slightly less for these regional ones which are only represented elsewhere. So we then feed it all back, and the pilot visit, our first pilot visit is in 2 weeks tomorrow. We actually start going around in January. Our pilots for individual trusts are in December, and I'm going to be coming to see you all. Hooray. So, what do you get at the regional presentation? Well, we talk about what the region is. We give some numbers about how many people are there, how many people get admitted. We give a fairly broad spread. There are about 97 questions in the census, and we give people quite a lot of information back as to where they stand with all those things by comparison. We use some other independent metrics like scanning rates and various things you can imagine. We got quite a lot of stuff that we focused on acute neurology. How many patients with neurological problems get admitted by somebody, even if they're not looked after by neurologists? So we can actually try and work out how big the inpatient population for patients with neurological disease is, and how should we best be trying to work out how to look after them. We got some interesting data on costs, so I'll just share a little bit of this. This is old data, but this is the cost per new outpatients by different trusts. And the interesting thing I think about this is, first of all, there's a vast variation. I'm told that the ones at either end are probably errors of some sort of accounting nature. But the interesting thing is that the specialist centres actually are neither more expensive nor cheaper than everybody else. So this background notion that a specialist centre is an inherently more expensive thing doesn't seem to be borne out. The same seems to be true for follow-up data. But we've got some money numbers. So what about MS? Well, we've got some stuff that we get from the census. We've got some stuff from HES, which is the hospital episode statistics, which is every time anyone's admitted, you get a reasonable quality data. And we get some data from Specialised Commissioning, particularly Malcolm Qualley, who I think is talking tomorrow, his stuff about drugs, for disease-modifying therapies. So what do we get? Well, we've asked how many MS clinics are there, how many MS nurses there are. We work, obviously, as to how many there are by population for these different things. And then the more specific disease measurements from MS, we say, well, how many people get admitted with MS? How many of those are under neurology? Does it vary? What's your length of stay comparison? So you can see the kind of thing you might want to know. How many day patients get admitted? And again, the proportion as to get actually looked after by neurologists. Worthwhile just bearing this slide in mind when I show you the next couple of slides. So these are the places, in order to have specialised commissioning, you have to be at one of these centres. Okay? If you provide the same service somewhere else, your disease-modifying drugs might be paid for, but actually the rest of the service isn't funded. And the reason that's interesting is that if you look at, this is all patients with neurological conditions where it's the primary admission, and this is, each little line is a different CCG. So this is a population-based rather than a hospital-based study, and you can see that there's really quite dramatic variation as to the rate of neurological admissions, almost a 50%, so 100% variation as to the proportion of patients that are admitted depending on where you live. And the blue stuff at the bottom is the proportion of those patients who have specialised funding allocated to it. So it's a bit random. So you can see if you happen to live wherever this is, just about half the admissions are specialised funded. And if you happen to live, just 2 or 3, well, in fact, the CCG 2 or 3 adjacent to it, almost none are. So we've got this extraordinary variation of specialised commissioning funding, or funded specialised commissioning. And if you then look at the same graph, this is now for patients with MS, and you can see, again, this is primary admission for MS. So it's not people with chest infection and MS, it's primary admission, cause of admission for MS by population. And you can see, first of all, there's a huge variation. Now, is it a coding issue? Is it a real change? But you've got a very high rates down to really very, very low rates, and much, much higher proportion of patients being admitted under specialised commissioning, but incredibly variable, even across this sort of trust. So we have quite dramatic variation, even at our first cut of the first simple data. So what other information have we got? Well, we've got information, and we will have more interesting information about the specialised commissioning. And the big problem with the specialised commissioning is to try and work out what population the spend is allocated to. And in a way, that's part of the reason we've been a bit fussy about trying to draw lines. And in fact, there are a couple of neuroscience centres that we're going to have to look at together because we can't cut them apart, okay, which means that people will have slightly pooled data. But obviously, we're interested in how much people spend, which drugs do they use. And I think Gavin's already mentioned this graph, which is from this data. And it's quite a complicated graph because each sort of little bar is going up is a centre. And you can see that the different drugs we've got there, what I think in the ABN guidelines, the high efficacy ones on the top, the red ones, the telizumab and the alemtuzumab, and the lower efficacy are the blue ones. And you can see there's this huge variation from 100% down to 100% on the other side. Now, we recognise that there's going to be artefact in this. So it may be that one of the blue ones over there, the only place you can get the red one is at the centre that does this, which is why we need to have the population-based data to try and make sense of this. The width of each of these bars, indicates the number of patients treated. So not very many, quite a lot more. But this variation, I think, is fascinating. And I think we're all against variation, apart from the fact that variation is what drives evolution. And the key thing is if we've got things which are done dramatically different and they make a big difference to outcome, potentially we might find that actually there's an evolutionary advantage. And the question is, can we try and use this kind of data to actually see through that? And whilst we would love a straight line across, are we missing a trick in doing that? Something to think about. So what are we going to find? Well, we know what we're going to find because everyone finds this. We're going to find the currently collected data is not very good. We're going to find there is variability in service provision, in access to service, in DMT usage, in admission rate. We're going to find variation. The question is, can we try and understand that variation and actually use the variation to try and improve matters? We will once again realise that our problem is we don't have simple, meaningful outcomes for MS, for a whole range of different diseases. But clearly thinking about those things and actually being able to collect them prospectively will be a good idea. And then obviously, from the MS data, how does it fit into the bigger picture and the logistics and the networks and all the other different things that we will hopefully find out about as we go along? Why does one area seem to be able to achieve so much more on fewer resources than somewhere else? So, what's the outcome? Well, the GIRFT doesn't come with any new money. Okay, the deal is, I think Tim Briggs upset everyone when his the orthopedics pilot was, well, the first report was launched, where he said that health service should be given no more money until we demonstrate we're spending the money we've got already in an efficient way. And I think that's, whilst we may be able to make a case for any money, we have to start with the premise that we probably aren't going to get any. We need to work out what does things well and how can we get everyone else to do it. And I have to say, I think just people, if they know where they stand, they change their behaviour. If you're coming last, you want to not be last. If you're doing well, you want to try and keep your advantage. We want to work out how to get better data, and I think, you know, the digitisation issue, the Bluteq, the whole range of different things attached to that. We need to rationalise specialised commissioning, which is in neurology is something of a dog's breakfast, and I don't think it's necessarily helping us, and we need to get a structure that helps us. And I wonder whether, I mean, you know, the slide I showed you constituted £250 million of spend, which is the kind of number which will get politicians interested. And so the question is, you know, where is good on that graph? Which is the best bit? Is it blue or is it red? We don't know. Is there some way in which maybe we could use this to actually try and find those things out? And I think we might need to be a little imaginative to see whether we could use the variability of practice as an accidental experiment to actually inform what the best thing to do is. So, GIRFT, it's using data to improve clinical services. I look forward to seeing you all. Thank you.
Save money. And the point you make, we don't know, coming back to what Charlie's saying about what's good variance and what's bad variance, we don't know where probably, you know, the very far extremes of that curve, we should probably be somewhere in the middle, but we don't know that. So it is possible, of course, that this is going to end up with a sort of very coherent case for spending substantially more money. We don't actually know.
Oh, absolutely. But I think the key thing is we've got, I mean, I think the interesting data set that I think we all are aware of is the SNAP stroke audit. The stroke audit is astonishing in the way it has completely driven the focus of a lot of trusts to try and get to be an A. You know, if they're a D or an E, the trust board gets emails about it. They really worry because they have data which ties them to not doing very well. And so I think if we can demonstrate huge variability, which I think we're probably going to do, then I think we may make the case for more money quite easily. But I think the natural history of developments in the health service is frequently the person who waves the most dramatic shroud, and children and cancer beat neurology pretty much every week of the year, gets the money. And I think we just can't presume that just because we'll have a great case, we'll get money. I think we have to show our house is in good order first.
Is there going to be an attempt to compare UK data with Scottish data?
So the interesting thing is the Scottish have bought GIRFT for orthopaedics and some of the surgical specialties. And the way in which the data is collected in Scotland is sufficiently different that it's not immediately comparable. But actually the hope is that we could do the same thing and the same methodology for Wales and Scotland. And if we do it well enough, they will be, you know, presumably one would hope they would want to do the same thing.
Can you hear me? Okay. I think a lot of the problem has been there's been certain inertia when it comes to neurology from the NHS front. So I was surprised to find out that we border as outpatient specialty under the CQC. So we never get our knuckles wrapped for underperformance. That state of culture needs to change before we can actually have a voice in the whole medical specialty.
I mean, one of the some of the visits I think are actually going to be most potent are going to be visits to trusts that have visiting or no neurologists, when I can go along and show them how many inpatients they have and their admission rates and their length of stay for patients with neurological disease in their hospitals that they're not providing a care for. And in a way, I think that's, you know, that's going to be, because you can do a back of the envelope calculation that probably a decent sized new DGH needs about 20 inpatients. But they will at any one time they will have 20 neurology inpatients at least with purely neurological disease. And the question is who should look after them, and that's another issue.
Nobody's going to escape this process.
No, nobody. I'm looking forward to visiting Western particularly.
Any other questions?
Hi.
we are aware of those figures and numbers. So I don't think, excuse me, you're telling me about how many patients I got on my trust at any given time. I fully know that because I got data that tells me every day. We are even a bit further ahead in some respect that we do try to capture some of the diagnoses that you talked earlier on about how many patients diagnosed with MS that's seen within the outpatients, because we don't, not in general, collected data. However, still, we are bottom of the line. If you go to beginning, we haven't got enough neurologists across UK. That's one thing. Second thing, when you start getting neurologists coming through, excuse me, the neurologist colleagues, either they are in movement disorders or something else, you can't get the sort of variable disease-specific consultants coming through to meet the needs, demands that is around. And then you go on to data collection. That's an even bigger nightmare, because no trust will operate in a similar way to the other ones. They still don't work on a business platform that says you ought to know how many people you got with certain conditions in order to deliver the service. And of course, you got the stroke that is on top, and then diabetes, and then asthma. And then we got our bed availability that is difficult to achieve. Incidentally, Luton achieved the best A&E waiting time targets, but that was at a cost.
I think the key thing is that we need to get on the agenda. I mean, you're absolutely right that, you know, I don't know. So I work at a DGH, and if you go to the medical staff committee and various things, you know, and as long as parking isn't on the agenda, it's all about acute medicine, you know, and neurology or any of the, it's to get us onto the sheet is very difficult. The advantage of the GIRFT is that we have a meeting with the chief executive, the medical director, and if we can show them coherent numbers to say this is a problem, then at least we're moving up that agenda and we can try and come to a solution. I think the solutions are likely to be more complicated by virtue of the fact that we're not walking alone. I mean, we've mentioned stroke, and stroke sees a vast amount of neurology, and a lot of neurologists do quite a lot of stroke, and a lot of patients who are supposed to have stroke don't have stroke. So we have to start talking to our friends and making them really our friends, which I think is going to be part of that process.
Geraint, thank you very much. I just want to know whether this data is collected anywhere, whether we know the total number of specialist nurses available in neurology across the country.
So we have that information from the census, but it's currently, we know, is incomplete. However, as we go round, the hope is that we'll show people, this is the data you gave us. And they'll go, oh, no, what about this, what about that, what are the... And that actually, by the time we've been through one iteration, that actually we'll actually have quite good data, even if our first set of data is not great.
Yeah, because it will complement what we're talking about.
Yes.
Yeah, thank you.
Thank you.